Hello, Damalie.
Hi, Jim. Can you hear me, Jim?
Yes, I can hear you.
Okay.
So I can do my presentation without video, right?
Without what?
Video.
Oh, yeah, sure. You can switch on the video initially to so people can see you, and then you can switch it off and make your presentation.
Okay. So am I very clear? Because I'm using um earphones, so I don't know if they are very clear and audible to you where you are.
Yeah, loud and clear.
All right. Thanks.
Yeah. All right. So now we wait for hopefully less than 5 minutes. Ladies and gentlemen, good afternoon. Welcome for this month's Day of Lung Science. Please give us a few minutes to allow more of our colleagues to join, and then we shall start shortly. Over. Good afternoon, ladies and gentlemen. I hope you can hear me. You're welcome for this month's Day of Lung Science, brought to you by the Pediatrics Research Group at the Makerere University Lung Institute. So as our colleagues join us, we're going to begin in the interest of time, and I will start with the house rules. Please mute yourself if you are not speaking. And then there will be actually an opportunity for us to discuss at the end of the presentation. So kindly forward your questions through the chat or wait until the end and you'll be given an opportunity to unmute and speak. You just have to raise your hand and then you'll be given permission to unmute and ask your question or clarify. So this month we are discussing bronchiectasis in children. Now, bronchiectasis is mostly described in adults, and we rarely commit to the diagnosis or even look for bronchiectasis in children. And we are here to demystify that. We want to know, is it a problem for children? Should we be looking out for it? And if we do find it, what do we do? So you can basically say, we are going to talk about everything you wanted to know about bronchiectasis in children, but feared to ask. And against that background, I'd like to introduce, I'm really happy to introduce the speaker, Dr. Jean Bangirana. Dr. Bangirana is a pediatrician at the Damalie Super Specialized Hospital, and she is currently pursuing her MPhil in Pediatric Pulmonology at the University of Cape Town Red Cross War Memorial Children's Hospital. We are really excited to hear about her experiences and about bronchiectasis in children in general. So please join me in welcoming Dr. Jean Bangirana to give her presentation for the next 30 or so minutes, and then we shall have a discussion. Thank you.
Thank you so much, Damalie, for that kind introduction. As she mentioned, I'll be talking about all the things that you'd like to know about bronchiectasis in children. It's actually not as uncommon as we thought, given all the risk factors that we have in our setting. I'll talk about a few things that are happening where I'm currently training at the University of Cape Town Red Cross War Memorial, but also some things which are practical in our own setting. So I'll just be speaking via audio, so I'm going to remove my video shortly. Okay, so bronchiectasis in children. This is going to be the outline of the presentation, really talking about what are the definitions we use, what is the epidemiology abroad and in Africa, what is the pathophysiology that brings about the clinical presentation, how do we investigate, treat, and then what's the outcome of these children. So bronchiectasis has been defined as a chronic condition. It affects the bronchial tree. It's characterized by dilatation of large and the medium-sized airways, which occurs as a result of damage to the underlying bronchial wall structure elements. And then the resultant clinical picture is a recurrent or a persistent cough. The European Respiratory Society has also put a definition for childhood bronchiectasis, which they've called a clinical syndrome. Sorry, I've lost my slides. I don't know what happened. Can you see my slides? Because I can't seem to see them.
We can see your slides.
Oh, for whatever reason, I think they've gone up. I can only see something else. Okay, let me check again.
You could unshare and share again.
Yes, yes, right. It's back now. Yeah, so they've described bronchiectasis as a clinical syndrome of recurrent or persistent wet productive cough. which occurs in the presence of airway infection and/or inflammation. And they also use abnormal bronchodilation, diagnosed on CT scan as part of their definition, which becomes a challenge in our setting in Africa because many places do not have access to CT scans. And even then, in our setting, CT scans are quite expensive. Even those who have the CT scans, not everyone can afford to do it. So you have a challenge of making a diagnosis without having a CT scan, but we shall discuss more of that as we go on. So I'm struggling with moving my slides.
Sorry about that, Dr. Bangirana. You might want to stop share and then share afresh.
Oh, okay. Let me try and do that. Okay. Okay. Okay, so in the risk factors that have been associated with bronchiectasis, in high-income countries, they managed to reduce the prevalence of bronchiectasis in children. Why? Because they've reduced their poverty levels, their living conditions are much better. So children don't get recurrent chest infections, recurrent lower respiratory tract infections, which are normally the precursor of bronchiectasis. And they tend to find bronchiectasis in children who have cystic fibrosis, children who have aspiration disorders, and those who have maybe inborn errors of immunity. However, there is a higher prevalence that has been noted in those who come from socioeconomically deprived populations. And these studies have been done in New Zealand and in Australia in their native populations. And the risk factors identified in those populations include those who have recurrent lower respiratory tract infections, the ones that have pulmonary tuberculosis, those who have a genetic predisposition, and like I said, poor socioeconomic conditions, as well as poor access to medical care. In Africa, however, despite the fact that we don't have a lot of data on bronchiectasis in children, I did find a lot of data on bronchiectasis in South Africa specifically. There are about 3 hospitals that have managed to document the bronchiectasis prevalence, and those include a hospital in Johannesburg, as well as the University of Cape Town Red Cross War Memorial. And one of them, the study that was done at Red Cross in 2019, from Jan to 2019, they were looking at a population of children aged 3 months to 15 years who are attending the chronic respiratory clinic. And they found that among 337 children, 58 of those had bronchiectasis. That gave a prevalence of 17%. So you actually look at that percentage, it's quite high. And another paper that was done by Vaui et al. Found that for the children who have bronchiectasis, the risk factors that predispose them to getting that include having a high burden of lower respiratory tract infections in these African nations, especially in South Africa, and especially children who get severe lower respiratory tract infections. So you have like a severe pneumonia, severe bronchiolitis, and they end up requiring maybe high levels of support, invasive ventilation, as well as even those who have pulmonary tuberculosis. In Africa, we also have a high burden of children who are living with HIV, because we know that 60% of children who live with HIV actually reside in sub-Saharan Africa. And so HIV predisposes to bronchiectasis by multiple mechanisms, including recurrent respiratory tract infections, pulmonary tuberculosis, as well as impaired innate and acquired immunity. We also have lower vaccine coverage rates for children in Africa. And if you have lower vaccine coverage rates, you'll get recurrent lower respiratory tract infections from Bordetella pertussis, strep pneumoniae, H. influenza, as well as measles. We also know that most of our population tends to have a lower socioeconomic status. There was a study that showed that many people are living below $1. So if you have low socioeconomic status, most people will be living in overcrowded areas, which puts them at risk of having recurrent exposure to recurrent respiratory tract infections. They can get TB easily. And many times these people are also the same ones who have no access to medical treatment. And as a result, even if they get these chest infections, they will not be able to access the medical treatment to halt the progress that would stop maybe the bronchiectasis from developing. We also have lower levels of education among health workers in Africa about how to manage a chronic wet cough. Many times we are not taught how to handle patients who come in with wet cough. How long should we treat them? Should we investigate them further? Should we follow them up? And how long should we follow them up? So I hope the talk can help us learn how we can manage these patients so that we can prevent bronchiectasis in a certain group of patients. So in the etiology of bronchiectasis, one of the commonest causes has been the post-infectious type. So many infections such as TB, HIV, adenovirus, RSV, influenza A and B, mycoplasma, and measles have been found to be the causes of bronchiectasis. And this type of bronchiectasis tends to happen with another chronic form of lung disease that is called post-infectious bronchiolitis obliterans. In South Africa, they have the privilege of doing what we call a viral panel, where they're able to screen for multiple viruses. So if you have a child, they have a severe lower respiratory tract infection, they're requiring high amounts of supplemental oxygen, we are able to do viral panels and be able to identify what's the pathology, what's the microorganism that's causing the disease. And that same study that I described that was done at Red Cross, they found that adenovirus was the most common cause of post-infectious bronchiectasis. So we find that it's something that we need to look out for, but in our setting in Uganda, I'm not sure how many places do viral panels. So that becomes a challenge in terms of identifying the etiology. But we know that TB and HIV are actually prevalent in Uganda. So those are other potential causes of bronchiectasis in our setting. This is another study that was done at Red Cross from 2019 to 2020 that was looking at post-infectious bronchiectasis. And they were studying children in the age 6 months to 15 years, and they found that still the most common cause of bronchiectasis was adenovirus. And most of these children presented with cough. Most of them required hospitalization, supplemental oxygen, and 75% of them actually required ventilator support. In terms of other causes of bronchiectasis that have been identified that are not so common, commonly described include aspiration syndrome. So foreign body aspiration. Many times a child will inhale a foreign body, they'll aspirate, they won't tell the family member, or they'll even forget, and then you end up having bronchiectasis. Last year we had 2 patients at Red Cross who had foreign body aspiration that resulted in bronchiectasis. One child had the whole left lung destroyed. We couldn't find out what the etiology was even after multiple investigations, but he ended up having what we call a pneumonectomy, which is surgical removal of the whole left lung. And on histopathology, they found a pen top within the lung parenchyma. And he hadn't even remembered ever swallowing, stroke, aspirating that pen top. So you find missed foreign body aspiration can end up resulting in bronchiectasis. Other congenital anomalies like tracheoesophageal fistula with esophageal atresia, laryngeal cleft, can end up causing recurrent aspiration, and as a result, bronchiectasis. Bulbar dysfunction, which is common in neurologically impaired children who have Down syndrome, can also result in aspiration. Preterms also tend to have bulbar dysfunction, swallowing incoordination, so they also aspirate a lot. And then structural anomalies like tracheobronchomalacia, where you have impaired mucus clearance, can present an opportunity for infections, chronic inflammation, and the whole pathogenesis. I wanted to highlight cystic fibrosis of these causes that I've listed here. I was quite surprised to find Black people with cystic fibrosis here in South Africa. I previously thought it was a disease of Caucasians, but actually, even Black people have cystic fibrosis. They may not be as many as the Caucasians, but they are there, which means in our setting, we're probably missing some patients who have cystic fibrosis. And they typically present with recurrent chest infections, wheezing, and malnutrition. So it's something for us to think about in Uganda. Then immunodeficiencies, which are inborn errors of immunity or acquired immune deficiencies, for example, HIV or post-transplant, post-chemotherapy. Such patients are at a risk of recurrent chest infections that put them at risk of bronchiectasis. In neuromuscular disorders, the problem is either aspiration from bulbar dysfunction, or they have a weak cough and poor clearance, and which predisposes them to getting recurrent infections, and then also the whole triad of bronchiectasis. So I just wanted to highlight the pathophysiology of bronchiectasis. It's been described that the Cole's vicious cycle explains how bronchiectasis comes about. So initially you have injury or some kind of infection to the bronchi or the parenchyma of the lungs. So once you have injury occurring, it triggers an inflammatory response. And this inflammatory response causes damage to the bronchial walls, the cilia, and then you end up having mucus sitting in the airways. There is impaired mucus clearance, and you also have hypersecretion of the mucus. Once the mucus is seated in the airways, it creates a favorable environment for microorganisms to end up colonizing the airway. So these microorganisms will come into the airway and they trigger, they cause infections, and these infections trigger an inflammatory process again. And this inflammatory process has been found to be more of a neutrophilic inflammation, though in a few cases there is a bit of eosinophilic, but it's mostly neutrophilic inflammation. This is very important because one of the medications that we use in managing bronchiectasis targets that pathway of neutrophilic inflammation. So you have this inflammation occurring, which causes worsening damage of the bronchi and the parenchyma. You have more damage to the architecture of the bronchi, and then the whole process keeps on going in circles. So infection, inflammation, impaired mucus clearance, microorganisms coming to colonize, more infection, more inflammation. And if you don't interrupt this process, before you know it, you have very severe bronchiectasis. So just a diagrammatic presentation of what the bronchus looks like when it's normal. It has this very good lumen, normal cell wall, and just enough mucus production. There are also cilia here, which you can't see very well. And then this other side, we have a damaged bronchus, which is dilated. We have hypersecretion, so you have a lot of mucus blocking the airway. And so the airway lumen is narrower, which would explain why these patients have wet cough. It would explain why they have wheezing. It would explain why they have obstructive airway disease. So in that whole pathway of bronchiectasis, the patient will initially start with a wet cough. And if the wet cough takes about 2 weeks, we normally call that protracted bacterial bronchitis. If you give 2 weeks of antibiotics to that patient, most times some patients will recover and then they won't have symptoms anymore. But some patients don't, their symptoms don't stop after 2 weeks. So you have to give an additional 2 weeks of treatment, so up to 4 weeks. And that's called PBB extended. Other times you get recurrent episodes of that wet cough, and so that's called recurrent PBB. So if after 4 weeks of treatment, symptoms are not resolved, then the patient progresses to what we call chronic suppurative lung disease, where you may have to intervene with intravenous antibiotics. If the intravenous antibiotics are either not given because you don't identify the patient or they don't resolve the infection, the patient will then progress to bronchiectasis. And in this whole sequence of bronchiectasis, at the point of PBB, the patient just has a wet cough. When you do an X-ray, there will be nothing to see. They might even not have any other features. The child may be playing. By the time they progress to chronic suppurative lung disease here, they may have features, because chronic suppurative lung disease can be even lung abscesses, empyemas, things like that. You may or may not have any radiographic signs at that point, but by the time they progress to bronchiectasis, the CT scan in the early phase stages of bronchiectasis, the CT scan is the best test to use. But by the time bronchiectasis has become severe, you can also diagnose it with a chest X-ray. So in the clinical presentation, we already talked about the chronic wet cough. The chronic wet cough, as you can imagine, is as a result of those secretions that are seated in the airway because we have impaired mucus clearance. They also tend to have exertional dyspnea. They get recurrent chest infections. Why? Because you have a microbial colonization and recurrent infections in the airway. There's wheezing, failure to thrive, hemoptysis, chest pain. They may also present with the clinical features of the underlying disease if it's an inborn error of metabolism, aspiration syndrome, or cystic fibrosis. On examination, so these examination findings, digital clubbing may or may not be there. You will normally see digital clubbing if you have advanced disease. Even chest deformities, hyperinflation, all those are features of advanced disease. So in the early phases of the disease, you may not actually see that. But the crackles and the wheezing are the signs that will be present even in the early stages of disease. So when it comes to investigations, if this patient has come to you, they have a chronic wet cough, obviously the first thing you're going to think about doing is sending off the sputum. So you're sending it for microbiology, you're sending it for TB culture, gene expert, and for fungal cultures. Why? Because you want to know what microorganisms are in the airway. You want to know if it's TB that's the cause of the bronchiectasis. If you have the means, then a viral panel would also be important to do. But of course, the definitive test, you have the cough, you have the clinical features, you want to do definitive tests. The chest X-ray, especially in Africa and in Uganda in particular, is a first investigation of imaging that would choose to do. But many times in early bronchiectasis, the chest X-ray will have non-specific findings. It may even be no. However, in severe disease, you'll see hyperinflation, you'll see atelectasis, which is really collapse of the lungs, and there may be cystic changes. The definitive test or the gold standard for bronchiectasis, at least from international guidelines, is a high-resolution CT chest. So here you expect to find dilated and thick bronchi, and dilatation is defined by having a broncho-arterial ratio of more than 0.8. So in children, we use more than 0.8. In adults, they use more than 1 or 1.5. You need to remember that. So there's also atelectasis, there's tram tracking, signaturing. We shall see all of those images. And in terms of bronchiectasis, it has been described as either to be cylindrical, varicose, and cystic. An important thing about the high-resolution CT chest is the fact that you can be able to predict some of the etiology if at this point in time you don't really know what the cause of a bronchiectasis is. If you have focal features of bronchiectasis, you're more likely to think of pathologies like a foreign body that has been missed. Because if you have a foreign body that is in a particular lobe of the lung, then you have only one part of the lung affected. Whereas if it's bilateral, then you're thinking about more diffuse diseases, cystic fibrosis, other aspiration syndromes, and the like. So we have these two X-rays. Here, we have a hyperinflated chest. So you can see by counting the anterior ribs, 1, 2, 3, 4, 5, 6, 7. This is a very hyperinflated chest. We have these chronic changes on the right middle lobe. We have a bit of a dilated bronchi and you can see some bit of thickened bronchi in the background. And then this other X-ray, you really have advanced disease. You have cystic changes all over the chest, and you can really see it's definitive bronchiectasis. So if you got such chest X-rays, you would be able to make the diagnosis of bronchiectasis without even having a CT chest. But in some cases, you're not able to find the diagnosis so easily. So you still have to go ahead and do the high-resolution CT. And in this case, you would see, like I mentioned, the dilated bronchi. So here we have, this represents the artery, and this represents the bronchi. So the inner lumen of the bronchi, the ratio of this to the outer lumen of the artery should be more than 0.8. And that's how we define a dilated bronchi. Here we have cystic changes that are visible. Down here we have honeycombing cysts and cylindrical bronchi. And then this is just a description of how the different types of bronchiectasis look: cylindrical, the varicose, and the cystic. So in early bronchiectasis, it's more cylindrical, then it progresses to varicose, and by the time you get cystic changes, then you know you're in severe bronchiectasis. So other investigations that you need to do, because imaging is good, it confirms the diagnosis, but it doesn't give you the etiology. And yet you need to know what the etiology of the disease is in order to arrest the cause and stop progression. So you have to do specific tests. The full blood count and the differential help you in just screening for immune deficiency at the very beginning. If you have an acute infection, the CRP and the blood culture can help you identify those. For cystic fibrosis, there are specific tests like the sweat chloride, the CFTR, which is a genetic test, and the fecal-elastase. Primary ciliary dyskinesia. So cystic fibrosis and primary ciliary dyskinesia are two conditions where you have impairment in mucociliary clearance for two different reasons. In primary ciliary dyskinesia, we have dysfunction of the cilia, so they're not able to beat properly, and you have the mucus sitting there and creating that whole vicious cycle. Cystic fibrosis, here you have the CFTR gene mutation causing mucus sitting in the airway, thick, sticky mucus that sits in the airway, creating an environment for that whole inflammatory cascade to take place. Immune workup in our setting is very important because we know that HIV is very prevalent. You always have to do an HIV test. The rest of the tests will depend on your setting and the patient, but HIV tests have to be fast done as you rule out other potential causes. In terms of aspiration workup, the first thing you ask will be from the history, asking about coughing and choking during feeds, whether the child inhaled a foreign body. If they haven't done that, then you may have to go ahead and probably get a speech and language therapist to help assess the child, do a contrast swallow to rule out tracheoesophageal fistula. A milk scan is a nuclear medicine test where you look at gastric emptying and reflux. And then bronchoscopy can be done if you're thinking about foreign body aspiration, if you're trying to rule out congenital airway anomalies like tracheobronchomalacia, and also do a bronchoalveolar lavage to get specimen for testing for microorganisms. So the Backpack group is a group of researchers in South Africa. Backpack stands for Bronchiectasis in African Children, Prevalence, Etiology, and Clinical Outcome. They decided to form a registry for bronchiectasis for children in Africa. And they came up with this schematic to help health workers, especially in an African context, to help diagnose and investigate bronchiectasis. Why? Because they felt like the European Respiratory Society guidelines were tailored to high-income countries, whereby the etiology may be slightly different from our setting. So in this schematic, they describe the starting point as a chronic wet cough. If you get a child who has a chronic wet cough, and the cough is unresponsive to antibiotics, or they keep getting recurrent wet coughs, even after giving antibiotics at least twice a year, you need to screen all those children for bronchiectasis. And their first point is a chest X-ray, but we've described that in early bronchiectasis, the X-ray might be normal. So if the X-ray is normal, but you have access to a CT scan, you would go ahead and do a CT scan of the chest and then confirm bronchiectasis or not. So if bronchiectasis is not seen on a CT scan in a child with a normal chest X-ray, then it means maybe at this point the child may have protracted bacterial bronchitis or another cause. And this is a patient who you would evaluate for other causes, but also make sure to give them a follow-up date to ensure that their symptoms are resolving. If the patient has non-specific changes on the chest X-ray, but you don't have a CT scan available, you will say this child has possible bronchiectasis, but then you'd still need to follow them up to make sure that it's not true bronchiectasis. And then if you have a chest X-ray where you have consistent signs of bronchiectasis, like we mentioned, hyperinflation, cystic changes, bronchial thickening, you would say this is unconfirmed bronchiectasis. But in all the patients in who you've diagnosed bronchiectasis, whether unconfirmed because you've not done a CT scan or confirmed because you have a CT scan, you must go ahead and then do investigations like we mentioned. In our setting, TB, HIV are the first line, and then the differential count with a whole blood count would be the next. And then as you keep on ruling out all the different causes, we've already discussed all those other investigations. So I wanted to talk about the management very quickly, the treatment. The goals of care in bronchiectasis, essentially you want to identify and treat the underlying cause. Why? If you do not identify and treat the underlying cause, then you will have the vicious cycle continuing. No matter how many antibiotics and therapy you institute, If you have not identified the underlying cause, you have chronic inflammation occurring and the cascade will never stop. Then you want to manage the symptoms and complications. You want to protect the lungs from further injury by reducing the number of exacerbations. And then you want to improve the quality of life. So the treatment essentially, like we mentioned, treat the HIV, the cystic fibrosis, the inborn error, treat all of them accordingly. Then you want to advise the family to avoid potential irritants, smoking, air pollution, biomass fuel, all of those have the potential to worsen the inflammatory process that's in the lungs. So you want to advise the family to avoid those, stop any smoking in the family. And then you want to institute airway clearance techniques. Because remember, these patients have mucus seated in the airways. It's a lot. There's hypersecretion, they have impaired clearance, so you want to aid them with the clearance. This is through chest physiotherapy. I'll just mention quickly in the next slide what you can do. Then nutritional rehabilitation. These patients tend to have failure to thrive malnutrition, so you want to monitor their growth and development, supplement them accordingly, zinc and vitamin D. Then you want to ensure that these patients get their routine immunizations. In that setting, ensure that the immunizations under 1 year of age are all given, because if you have bronchiectasis at the beginning say you already diagnosed bronchiectasis, and then the person or the child keeps getting more insults, every time they get an insult to the airway, you're damaging the airway even more, so there's progression of disease. So you want to ensure they get their immunizations and they're not at risk of getting further insults through recurrent infections. In South Africa, they have access to influenza in states. I think in Uganda, it's only given in private. Maybe one day we'll get there. And then immunomodulation. Like I mentioned in the pathophysiology, there is neutrophilic inflammation going on. From multiple studies, azithromycin has been found to be an immunomodulator and suppress that neutrophilic inflammation that goes on in bronchiectasis. So it is used for long-term care as 10 milligrams per kilogram given Monday, Wednesday, and Friday. The minimum period is about 6 months, after which you then observe and see are the number of exacerbations reduced or not. If they are reduced, then you can give a break of 3 months and see how the child does. If the exacerbations return, then you would have to give the child azithromycin again. And then aggressively treat any pulmonary exacerbations that occur. If your patient has airway hyperresponsiveness by a positive bronchodilator response test, either via spirometry or clinically, then such a patient would benefit from bronchodilators. But not everyone who has bronchiectasis should be given a bronchodilator because it's not been found to be helpful in all patients. And then lung function has to be monitored routinely at every visit, either via spirometry for those who are eligible, 6 years and above, or through the forced oscillometry technique. So these are just techniques, airway clearance techniques that can be done. They depend on the age of the child. Infants, you can do positioning, percussions, vibrations. As a child gets older, you can use devices, you can encourage them to do vigorous exercises. And in particular patients like neuromuscular patients, you have to give what we call breath stacking or mechanical insufflation. So I just wanted to describe what you would do for a typical patient if they came to you at a clinic visit. Ideally, these are patients who you want to monitor every 3 to 6 months. A patient comes in, the moment they come in, you're asking them, do they have a chronic wet cough? Have they been coughing every single day? Is it productive? What's the color of the sputum? Do they wheeze? And then you ask about the complications, which we'll discuss. You need to ask them how many times they've required to be admitted over the last maybe few weeks that you haven't seen them. You need to educate the caregiver about the exacerbator, smoking, airway pollution. You need to address the underlying disease and make sure that you're treating the comorbidities. You have to make sure you plot anthropometry at every visit. And if the child is malnourished, you need to refer them for rehabilitation because malnutrition has been found to worsen bronchiectasis if not addressed. If possible, it would be good to have a physiotherapist in every clinic visit. If not, then you, the health worker who is seeing them, should teach appropriate airway clearance techniques to the caregiver and ensure that they are compliant with them at home. If a patient is productive, you need to make sure you're doing sputum surveillance. So this helps you because the next time the child has an exacerbation, you know what microorganisms are colonized in the airway, you know what antibiotics can clear that microorganism, and then you treat appropriately. Ensure that you're checking the vaccination status, and then repeat imaging only if needed, and especially this occurs when you have an exacerbation. So what is an acute pulmonary exacerbation of bronchiectasis? You will have a patient coming in with a new onset cough, dyspnea, chest pain. They'll have increased sputum production or change in color. There'll be wheezing, effort intolerance, plus or minus fever. So in such a patient, of course, you'll want to do the full blood count and check, is there bacteremia or not? And then you'd want to send off the sputum. And based on your previous sputum surveillance, you would want to give appropriate antibiotics. So most times from all the studies that have been done, the most commonly cultured microorganisms in children with bronchiectasis are H. influenza, Moraxella catarrhalis, and Staph aureus. In a few children, you have Pseudomonas, but most times it's H. influenza, Moraxella. Then you'll do a chest X-ray and lung function tests. If the child is hypoxic, you will need to admit them and give supplemental oxygen. If not, they are just productive, but they are not hypoxic, they're not danger signs, you can manage them as an outpatient, but you have to give them antibiotics for a long period, 10 to 14 days. Why? Because they have poor clearance, they have lots of mucus in the airway. So it will take long to clear that whatever infection is in the airway. It can't be 5 days, it has to be minimum 10 days, but 14 is the recommended days. If you have a child who isolates Pseudomonas, you have to make sure that you give particular antibiotics. So if the patient is stable, you can give ciprofloxacin orally for 14 days, and then you have to give them inhaled aminoglycosides. In the developed world, they give them tobramycin, but in South Africa, they tend to give more amikacin, or as we call it, amikacin. Yeah, but you have to make sure you clear the Pseudomonas. If you don't clear it, it has been associated with recurrent exacerbations and deterioration in lung function and progression of disease. So it's one of the microorganisms which you need to clear. If the patient is very sick, you would have to admit that patient and give them maybe piperacillin, tazobactam, and amikacin as well for 14 days minimum. When the patient has an acute exacerbation, you have to encourage them to do intensive airway clearance at least 2 to 4 times a day, because they have more mucus secretions, and so they need to be cleared. Those are the complications, as we know: recurrent chest infections, chronic obstructive airway disease, failure to thrive, sleep disordered breathing, and long-term, they also tend to have pulmonary hypertension and copulmonale. So in terms of the prognosis, patients do well if you manage the bronchiectasis well and address the underlying cause. But if you don't treat the bronchiectasis, they will have worse disease and a poorer prognosis. So you really want to hold the number of exacerbations that patients get. A surgery for bronchiectasis is not commonly done. It's only done after you've maximized all the medical therapy and you've failed. And it's typically done for focal disease, like I mentioned, someone who has only one side of the lung or one lobe of the lung. That is when you should consider surgery. So I wanted to highlight the prevention. How can we prevent bronchiectasis? We mentioned that one of the risk factors is having low vaccine coverage rates. If we don't immunize these patients, they get recurrent lower respiratory tract infections, which can result in bronchiectasis. So if we do routine childhood immunizations, promotion of breastfeeding, we can reduce the number of pneumonias and the lower respiratory tract infections that these patients get, which would reduce the number of cases of bronchiectasis. Another thing is to identify early patients who would have protracted bacterial bronchitis, chronic wet cough for more than 2 weeks. These are patients you should treat aggressively. Treat with antibiotics, follow them up, and then make sure that they don't progress to bronchiectasis. Identify risk factors like HIV, treat it in time, start at early, PMTCT programs. Make sure patients who have been diagnosed with TB are fully treated, and you follow them up to completion so that they don't get post-TB lung disease or bronchiectasis. discourage things like smoking and vaping, and improving our air quality by avoiding air pollutants. And then most of all, training, like we're doing right now, training clinicians in how to diagnose bronchiectasis, identifying children who are at risk, and making sure that we treat early, because bronchiectasis can actually be reversed if it is identified early and treated on time. So that's my take-home message: prevent bronchiectasis. Once you've diagnosed it, make sure you identify the etiology, address it, so that you hold the progression of disease. And once you have patients who have bronchiectasis, closely monitor them after follow-up. Thank you.
Excellent. Thank you so much, Dr. Bangirana. That was such a detailed and really helpful presentation. Ladies and gentlemen, I neglected to say that you can actually access your CPD points for this webinar. Please click on the link in the chat, and please, I have not seen any questions in the chat so far, but please feel free to raise your hand and I will call upon you to unmute and ask your question. In the meantime, I will ask Dr. Bangirana, is it actually possible for a child to recover completely and recover their, lung function completely following bronchiectasis, and in what circumstances would that be possible? Thank you.
Thank you, Dr. Damalie, for the question. So recovery of lung, reversal of bronchiectasis depends at the point which you diagnose the bronchiectasis. Like I mentioned, if somebody has early bronchiectasis, they just maybe have had that chronic cough for a while. You do X-ray, there's no sign of any changes. And then when you do a CT scan, there's bronchodilation, yes, but it's very little. In a patient who doesn't have like an underlying risk factor, for example, no HIV, they don't have an inborn error of metabolism, no cystic fibrosis, essentially nothing that is chronic. At this point in time, if you manage such a patient, there is hope that you can actually reverse the bronchiectasis. It has been shown in studies in Australia by one researcher called Ann Chang, who is a lead researcher in bronchiectasis, that once you arrest bronchiectasis early, you're actually able to reverse the clinical features as well as the radiological imaging. In patients who have underlying chronic conditions, even if you identify the bronchiectasis early, the lung function may not necessarily go back, but what will happen is that you have plateauing of the lung function. So the disease progression is halted, and you just have plateauing of the lung function. In some cases, it actually gets better, but it doesn't completely get better. Maybe you'll have lung functions of up to 75, 80%, but you won't necessarily get 100% FEV1 in such patients. I hope I've answered your question.
Yes, you have. Thank you so much. I think there is so much hope. We sometimes see these children at the very end when you make the diagnosis too late. So we think that everyone else is going to follow the same course. So we appreciate sharing that and your experience over there with us. Now we shall have Dr. Grace Kadondi. Please unmute and ask your question.
Okay. Yeah, thank you, Dr. Damalie and Dr. Jean. I have three things to ask. The bronchoalveolar lavage is used like to get the fluid for investigation. Would it also be used as part of the treatment modality? And maybe nebulization, say with saline, would it be useful? Then the other thing is if they get complications, say like abscess, I know they can have drained and what, but how long would the antibiotics be given in that instance? Thank you.
Thank you, Dr. Grass, for your question. About the bronchoalveolar lavage that's taken during bronchoscopy. It's not routinely done. In fact, I wanted to ask how many centers in Uganda are able to do bronchoscopy with bronchoalveolar lavage apart from the Makerere Lung Institute. I'm not so sure. But we normally do it in patients who we are suspect maybe a congenital airway abnormality, which we want to diagnose, or two, you've tried to obtain a specimen to identify the microorganism, especially like in TB. You think the patient really has TB, but all the sputums that you've gotten induced and otherwise, you can't get a sample. So the bronchoscopy and bronchoalveolar lavage would help you get a much lower respiratory tract sample that you then send off to the lab and confirm the diagnosis. It's not used for treatment in bronchiectasis per se, but I heard you talk about the nebulization with saline. So nebulization with hypertonic saline is used in particular types of bronchiectasis, like cystic fibrosis-associated bronchiectasis. There's a lot of research in that field, but non-cystic fibrosis bronchiectasis, it's not routinely recommended. And it's only recommended in a few patients who have problems with clearance. For example, you've tried all those airway clearance techniques, the chest physiotherapy, the percussion, vibration, the instrumentation, and you've really failed to clear the secretions, and you have this patient who is struggling with secretions, then you'd opt for that individual, maybe NEBS hypertonic saline 5 to 7%, right before you do it, right before you institute the chest physiotherapy, but it's not done routinely for every single patient. Then about the complications, if patients get lung abscesses, you have to treat for at least 4 weeks of antibiotics. 4 weeks of antibiotics. If you don't give at least 4 weeks, you won't have good penetration, you won't have good clearance. I think I've answered the question.
Brilliant. Thank you so much, Dr. Bangirana. We have really learned a lot from you. I see more comments in the chat, and they're just saying they're so grateful. They have found the presentation very insightful, and they're very proud. We are very proud to be associated with you and look forward to you returning home so that we can, implement some of these together. Now, ladies and gentlemen, I hope you can see my screen. This year, the Lung Institute celebrates 10 years of lung health impact. I think they have done an amazing job so far. So, the jury is still out on what they're going to do over the next decade. But please take note of the activities that will be happening throughout the year, culminating to 27th and 28th November, where we shall have the scientific conference and anniversary ceremony. Before that, we shall be having webinar series, community outreaches, and also present documentaries about, how much impact the Makerere University Lung Institute has made in people's lives and in the scientific community. So we look forward to sharing all those activities with the rest of you. That said, right, unless Dr. Bangirana has any closing remarks.
Thank you for the opportunity to speak today. I think my closing remark, and something which one of my supervisors, stroke consultants here told me to pass on, is the fact that bronchiectasis can be reversible if it's diagnosed early, especially in certain cohorts of patients. But even before the reversibility, it can be prevented. So we need to do our best to try and prevent as much as possible. Prevention, immunization, also ensuring that every time you get a child with respiratory tract infections, treat them appropriately, follow them up, see that their symptoms have resolved. And if they don't resolve, then you need to investigate why. So that's more of a prevention. And then once you diagnose it, have a quick eye or think about it every time you get a patient. I know in Kampala, there are many mothers who come back, oh, my child is still coughing. And many times we give a cough syrup, not even an antibiotic, a cough syrup, and tell them it will go. But maybe if we give the appropriate antibiotics. So I didn't mention this, but the most common cause of, the most common microorganism associated with protracted bacterial bronchitis is H. influenza. So such a patient, you would want to give them amoxiclav. So augmentin, amoxiclav in that period of the 2 weeks, and then you monitor. No resolution, another 2 weeks for amoxiclav. Even as you're thinking about doing imaging, the chest X-ray, and then the CT scan. And once we've diagnosed bronchiectasis, let's follow up these patients, because many of them can have halting of the progression of their disease and have very good qualities of life. I see very many patients here. We see them in clinic, but they have no symptoms. 3-4 months, no exacerbations. And azithromycin is a wonder drug. It does wonders when it comes to preventing exacerbations. So utilize it as much as possible, but also think about non-tuberculous mycobacteria as you give it. So that if a patient has had 6 months, no exacerbations, don't overgive azithromycin. Stop, give them a break, and then only give when the patient has started getting exacerbations again. Thank you for the opportunity otherwise.
Thank you very much, Dr. Bangirana. Very strong closing words there. This is preventable, this is treatable, and cure is imminent if you are diagnosed early. So thank you very much, ladies and gentlemen, for joining us today. And please join us again next month for another insightful and interesting conversation about lung health problems in general. Have a lovely evening.
Dr. Nalwanga, before we leave, Dr. Nalwanga, some of us joined late who are requesting if we could have the recording and the slides to go over them if possible.
Sure, that is okay. The session is recorded. Please do send me an email and I will share.
All right, thank you so much.
All right. Have a great day, everyone. Bye.